It's a pleasure to be here with you all. It's great to see such a great and dynamic audience. I want to talk today about our company, Elemeno Health. We've developed the first personal assistant for frontline healthcare teams. And when we think about frontline healthcare, what are we talking about? Historically, software companies have been looking at healthcare as this dyad, a dyad between doctor and patient. We've got a lot of doctors in this room, but let me ask you, when you're in the hospital, who is providing care to that patient? Who's providing that care to the patient day in, day out, all hours, day or night? Any thoughts? Anyone want to throw it out? Nurses, right? So it's the nurses that are doing it. We have 800,000 doctors in America, but we have 3 million nurses. We have over 1 million ancillary staff. We, as physicians, are the commanders of a team, but we cannot win this battle unless we can engage and empower our troops, and that's what we're about. What is my perspective on this? So I'm a pediatric intensivist. It's a rare kind of ICU physician who, for the past 20 years, has taken all of my call in-house. That means days, nights, and weekends. So that means when an order goes in, I'm actually able to follow that from the order all the way to execution on the patient. And I can see the impact that it has and the variabilities on all of the staff. I've seen this in the settings of Stanford, at Kaiser, UCSF, and Children's Oakland, all with the same kind of problems. Now, I've been, last 5 years, medical director of the ICU at UCSF Children's. I've been joined in founding this company with Ed Nanali. Ed comes from the gaming world. 20-year career in game development, starting at LucasArts, last 14 at EA, pushed out SimCity to 2 million people. And the third person in our leadership group is Carol, the rare combination of RN and JD. Former Chief Compliance and Privacy Officer at UCLA, similar position at Lucille Packard, just retired from UCSF, where she worked together with me on our prototype. So we back up to think about what the problem is. It's actually underscored by some of the things that we're seeing here today. Medical complexity is growing at a crazy pace, exponentially. We see so many wonderful devices and different ways of looking and solving problems that are coming out. That knowledge is blowing up, but we still expect the people on the front lines to be able to understand every one of these devices, to be able to interpret it, and to be able to execute on it the right way. There's a growing knowledge gap between what we know at the institutional level and what is happening in the static capacity of our brains. A generation ago, or two, our parents, when they were kids, the nurse maybe had 5 tasks. Now she or he has 500 or 5,000. He's unable to actually master that. And as a result, people are getting stressed. We find increasing inconsistencies. We find errors, now the number 3 cause of death in the United States. We find enormous waste. Workflow inefficiency is costing us up to $200 billion annually, and people are burning out. You've seen that with your physician colleagues. Maybe that's why some of you have actually gone into health tech instead. Over 50% of physicians have burnt out. Nurses are not far behind. So our solution is the first personal assistant for frontline healthcare teams, how we can engage and empower them. Our goal is to be able to close that knowledge and doing gap and help people bring the right practice to the right person at the right time. We're cloud-based SaaS, available, accessible across any device. So what we do is, first of all, is we take that institutional knowledge that is lost in various corners of your hospital, whether it's in email or it's in SharePoint, in some places in the cookbook binder, or it's sitting on another various different websites. We can connect that and give it to people in one place, make it easily digestible into bite-sized microlearning. Smart checklists, best practice guidelines, concise how-to videos, consumable directly at the point of care. We can promote the adoption and adherence to key best practices through social drivers. Nurses and staff are very social creatures, and what we're able to do is use peer-to-peer recognition and gamification to drive that engagement. And then we can turn around and we can analyze metrics. What are people looking at? There's so much focus on patient data. What about the behavior of our staff? If you're the plastic surgeon and you're doing a patient with a flap and you're hoping that people are going to actually follow your pathway, wouldn't it be nice to know if the nurses over the weekend actually even looked at it? So that's the kind of stuff that we can do on a very granular level with our users. And our system works. The prototype that we used, we picked one target and we studied that. This was central line infections. We know with line infections, if you take care of the line the same way day in, day out, follow the best practices, your infection rate will drop. So we took UCSF Children's, we cut it in half, we took half the hospital and exposed them to our prototype. We ran this over a year. Between what was expected based on prior year rates and what actually happened, our infection rate dropped 50%. We saved over 300 hospital days, and that translated to a savings of 1.1 million and ROI between 10 and 100x. Our control arm, they actually did worse. So if we adjusted this rate for the control, we were 69% less than what was expected. So let me show you a little bit here. This is both from a traction standpoint, how our users are looking at this and how the It's a quick idea of what this looks like, and you can see the passion in the users. What you saw there was a nursing director, we saw a attending physician, and we saw a bedside nurse with 27 years experience. And they speak with this with a lot of passion. It helps them. When we looked at our pilot data at UCSF, we surveyed our users. Our net promoter score was positive 43. That's on a minus 100 to plus 100 scale. That was, really for something in healthcare, great. 67% of our users were accessing via mobile device, and 17% were actually accessing from home, extending their learning of best practices outside of their work hours. From that first video, we exploded to over 20. We're expanding into the adult units, transport, and through safe patient handling, a common problem that every hospital has and that Cal OSHA is now putting standards on. The University of California Office of the President is looking at using our platform to share best practices across all 5 UC Med centers. So we have instances running here in 3 different members of the UC family. In only 6 months since we started, we have our first sale. That was a small sale, 50,000 SaaS. And we've got an LOI from Alameda County Healthcare Services Agency to use our platform to engage 9 different clinic systems in Alameda County to drive the adoption and adherence to opioid prescribing and management best practices. And that's caught the attention of NIH and the National Institutes of Drug Abuse, for whom we've got an SBIR grant in the works. Hopefully we get through with that. We've got multiple systems in the pipeline, and we're looking to raise capital to help to service that pipeline. What sets we're the first to market with this product. We bring on-demand microlearning. Really, it's adult learning theory. It's no more of train here and execute here, the tradition of medicine. Bring it to you what you need when you want it, the way we do in our consumer lives. The EHR is a record of what we have done and what we need to do. We're about the granular on how to actually do it. As our customers grow and more best practices come into the system, we have a network effect, increasing value. And from those of you on the IT, we're very easy for IT. In other words, we can deploy technically without IT. We're all on the cloud. There is no PHI. It avoids the HIPAA issues. You can deploy without burdening your IT systems, and you can keep it personalized for your hospital. We have started over here in acute care. We have clients now who are coming on in ambulatory, and we have strong interest from long-term care all the way down to home care. The information that we gather here, that platform, feeds the entire continuum of care. We started here in June when I left UCSF to join with Y Combinator. We launched our pilots in the fall. We won a Medi Award at XMed back in October. First contract sale in December. We've now in a partnership with Berkeley as well through the Engineering for Children's Health Initiative. We'll be presenting at the American College of Medical Quality and the Pediatric Academic Societies later on this year. Ultimately, we want to take our checklist to voice, completely untethering people from hardware, being able to talk them through key steps that they're doing, create this shared marketplace of best practices where we can really identify across hospitals which practices truly are the best, help elevate us as an industry, and ultimately apply machine learning, tying process and outcomes, and to be able to help end users know this is what your peers are looking at, this is what you should be doing too. Our advisory group, proud of the group we have, early stage Yahoo, former vice president of product at LinkedIn, the new CEO of US Telecom, which is the #1 broadband industry group in DC. And a variety of other senior folks who've been around the block and really can help us in growing this business. We've raised $385,000 to date in safes from angels and YC. We want to bring in another $600K this year, which will allow us to expand from growth in sales and to be able to set us up for Series A in end of first quarter of 2018. So that's us. Happy to take any questions. Back in the corner there.
Yeah, great presentation. One comment and one question. The comment is, I think you're on something your last slide we talked about just-in-time training.
Yeah.
So if you can, because you're right, there's so many devices and operations training, if you could play an audio track or training and say, hey, this is what you do with the device, that would be great. The comment is, I'm struggling to understand how no PHI is supported. If you're giving, nurses and checking on the follow-up of a patient post-surgically.
So in this case, it would be, who's the plastic surgeon here? That was, yeah, picking on you. So, I'm sure you've been frustrated at times when you've done a certain surgery and you expect that flap to be checked a certain way or that wound vac to be changed a certain way. And people, just coming on nights and weekends, they just don't know how to do it. And they do it wrong. But you've got a rock star nurse who can do it right. Or you've got a little packet on how you're actually supposed to do it. If that information, which already exists, is here on the platform, he can trust that nights and weekends, the other people are coming on, can just pull wound vac, and they can pull that information right there. So it's empowering people with the knowledge to use the devices that are there in front of them. It's not so much saying, did the patient who was receiving that device do? It's kind of subtle there. But what we're looking at is that You know the EHR is giving you the orders of what to do. We're delivering you for you the information. And once you know what to do, how do you actually do it? So I think you were next. Yeah. Okay, so for how long are the videos? The videos are generally, we target for around 2 to 3 minutes in length so that you can actually, in context, do it. An example I would give is I had a family complain to me, I don't want these nurses taking care of my daughter because they were trying to access her port and they had the binder there and they were looking through the steps while they were doing this. But when they have the video, they can look at it quickly or they can even show the patient, hey, this is our best practice. I'm refreshing right before I do it. And then when you asked about the opt-out, I want to clarify, what do you mean opt-out in which way?
When you're thinking if my day is already X number of hours, I don't want to spend another 5 minutes in another video for people to know them.
Oh, yeah, if you've done it, there's no mandatory requirement for you to do this. This is to help it make it easy. What our nurses tell us, I spend so much time running around trying to find the information. If I can get it for me right in front, I'll do it. The central line piece is a case in point. Tremendous variability because people would just wing it. When they saw the right way, they would do it the right way. I think there was one other question back there.
Do you have regional clinical guidelines? And I typically tell that to the EHR.
So the clinical, if you try to morph a clinical guideline in the EHR, it's generally a long and painful process. This is one that ultimately the tools are there that the managers can actually go in and do this themselves. So there's a lot of guidelines that are already sitting there on the shelf that are frankly not in the EHR and that people don't want to invest the time to do this. This makes it very simple to take it up, take it down, to modify it. Everybody always gets the most current information. Well, so, all right, so that's perfect. So if you're a company with, well, maybe your MRI thing wouldn't quite work on this, but a different kind of vendor, maker. But now I've got to hope that those staff, remember, I better go look at Medtronic and find that thing. That link can come sit directly in here. So when they search Pacer, boom, they go right there. Something to Medtronic, something to Philips, something to GE, it's all relevant to what they're doing locally. A subscription, yeah. It's a subscription model based on seat licenses, yes. So our first 2 LOIs, which I feel I grossly underpriced because they agreed very quickly, were at $20 per user per month. And now with our incoming customers, we've been quoting at $50 to $75 per month, using an analogy that others have talked about, an hour of training. But we're going to give them access 24/7, 365.